Hello, and welcome to Attentive Healthcare Solutions webinar on NCQA PCMH Certification for NextGen Enterprise. My name is Chelsea Grover, and I'm the Marketing Communications Coordinator for Attentive. Before we dive into today's webinar, I wanted to take a moment to explain the process for the presentation. First, I'd like to mention this webinar will be recorded. We'll send out a copy of the slides along with the recording within the next week. Next, for those of you who aren't familiar with Attentive, I wanted to share a bit of who we are with you. We specialize specifically in NextGen healthcare, and we're passionate about providing solutions for healthcare provider partners, which in turn help them to improve patient care, enhance the patient experience, and maintain a financially healthy practice. To sum it up, we do everything NextGen, and we also have NextGen add-on productivity solutions, including ChartGuard and Refund Manager. Next, I wanted to mention an upcoming webinar that we'll be presenting on December 2nd. It's going to be on minor medical records, navigating parental and patient rights. Establishing general guidelines for your practice when dealing with minors and their rights can be complicated, particularly in today's heavily regulated environment. In this educational webinar, we'll analyze state regulations and the challenges they present. I'll be emailing an invitation for this informative webinar later in the month, so keep your eyes out for that. Okay, so back to today's webinar on PCMH certification for NextGen Enterprise. At the end of the presentation, we'll open the floor up to questions from you. We'll answer all the questions at the end, but you can type them in the questions area of the webinar control panel whenever they occur to you. And finally, for audio clarity purposes, everyone's phone will remain muted throughout the entire webinar. If you experience audio issues, please use the chat box to let us know so we can resolve them. And again, questions may be entered in the questions box. So without further delay, I'd like to introduce our presenters for today. Lindsay Lanning is Manager of Client Development, and Carly Hogan is Client Solutions Administrator at Attentive. So Lindsay, the webinar is all yours. Feel free to get started when you're ready.
Great, thank you, Chelsea. And hi, everyone. Thank you for joining us for our webinar on transformation and annual reporting for NCQA PCMH. Today's presentation, ideally will be beneficial no matter if you are already part of a PCMH currently or if you're considering becoming one in the future. Either way, if you just don't feel like you have all the information you need to ensure success, you've come to the right place. We are going to address questions and concerns of PCMH transformation, as well as annual reporting, as well as the COVID-19 impact this year. So we understand, what's required, best practices to be successful using NextGen, and how to make your practice and providers more productive and profitable under this model. Now, as a disclaimer here, we are strictly focusing on the NCQA PCMH program. No other type of PCMH recognition will be covered, although many of the general concepts we cover in regards to, practice benefits or ROI on PCMH and overall, how to elevate the conversation would apply. I thought it was important to point this out sooner rather than later. I also wanted to point out, as an NCQA PCMH CCE, I do have access to a lot of amazing resources and in-person training that largely fed into this webinar. So most of the graphics and a lot of the overall content that has been taken directly from NCQA in order to provide you with consistent and accurate information. One of our goals with this webinar is to make all of this information easier to dissect and digest at the practice level. So where I had 400+ slide presentations from NCQA, I was able to scale it down and pick out what you really need to know and add in what you should know. A lot of the takeaways and tips are coming directly from NCQA evaluators who conduct transformation and annual reporting requirement reviews. So let's go ahead, jump right in. Up first on our agenda today is really just introducing or reintroducing you to the PCMH Basics. Now, if you are already a PCMH and completed transformation, this will likely be review. However, there is still some great information to reiterate the importance of this program in your practice and maintain practice support. It will also serve as a great refresher to you on what is required until we get to the annual reporting section, where I know an abundance of you are currently gearing up to complete as well. So for those of you on the call who are not yet recognized, you may be wondering, what exactly is this? If you joined because you're curious, you've heard PCMH a lot recently, we're going to dive into this kind of definition here and an overview of it. So the patient-centered medical home is a care delivery model whereby patient treatment is coordinated through their primary care physician to ensure they receive the necessary care when and where they need it in a manner they can understand. So the objective is to have a centralized setting that facilitates partnerships between individual patients and their personal physicians. This is really there to emphasize care coordination and communication to transform care based on your patient's preferences and needs. So the patient-centered medical home really is a model of care that, as it states, puts the patient at the center. PCMH builds better relationships between patients and their clinical care teams. And I also want to note, because I get this question a lot, PCMH recognition is voluntary for practices. You choose to participate, it is not required, but it puts your practice at an advantage in so many ways, which we'll go over in a few slides, of how to recognize and relay that value of PCMH to your team. So how do you gain buy-in at your practice if you're new to PCMH? Or on the flip side, how do you sustain support if you're already recognized? Well, you want to start with these main points. You can talk about how it reduces fragmentation and improves quality of care. Again, this PCMH model emphasizes team-based care, focusing on communication and coordination, which has been shown to lead to better care. Many patients also acknowledge PCMH recognition as a hallmark of high quality care. Earning PCMH recognition means you're providing patient-centered care that's associated with higher quality, better patient satisfaction, and reduction in any avoidable costly visits to the ED or hospital. So as a result of that, many payers actually provide incentives to PCMH recognized practices. Payers can offer benefits ranging from enhanced reimbursement, buzzword there you can always use, to preferred provider status. They could also offer complimentary coaching or practice support with this model. And we've also found this can really help you negotiate different contracts and rates with your payers as well. The PCMH model is associated with better staff satisfaction and patient experience, which we'll dive into a little bit later. It's also shown to help better manage patients' chronic conditions such as diabetes. And as more emphasis is placed on value-based care, many state and federal programs are embracing the patient-centered model of care. I think we're at 29 public sector initiatives, and about 25 states actually require the use of NCQA PCMH recognition as part of their medical home initiative. And states like Tennessee and specifically New York are adopting PCMH recognition to help improve the overall quality of care in their states. Also, research shows PCMH recognition actually improves patient care and reduces cost. One of the pilot programs that NCQA conducted showed actually a 9.3% reduction in emergency department utilization, which resulted in approximately $5 million in savings per year. Another study found PCMH recognition was associated with $265 lower average annual total Medicare spending per beneficiary, which if you report under MIPS, under MACRA, that's one of your cost measures as well. Can never leave MIPS out too far from any webinar. PCMH also emphasizes the use of health information technology and after hours access. So you're looking at improving overall access to care when and where your patients need it as well. It will align with where healthcare is headed. I mentioned kind of before, payers continue to move to that fee-for-service model, from that fee-for-service model towards integrating, rewarding integration and quality care, focusing on value. And they're increasingly contracting with organizations that can show they have a strong infrastructure and quality improvement initiatives in place. And then last but not least, marketing your practice. NCQA publishes a list of all recognized practices and clinicians in its recognition directory, which is available to the public. You can also, once you're recognized, use the official NCQA seal to actually market your accomplishment to patients and partners as well. It's very well known. Now, if your providers are still questioning you, give them these details on the clinician benefits. And I would obviously start with number one, earning higher reimbursement. So more than 100 payers nationwide offer either enhanced reimbursement for recognized clinicians or support their practices to actually become recognized. I would also mention, succeeding under that MACRA QPP program under MIPS that I mentioned. CMS acknowledges both NCQA PCMH and PCSP recognition programs as ways to receive MIPS credit. You would actually automatically earn full credit in the improvement activities category. They can also earn maintenance of certification credits. So several medical boards award clinicians in NCQA recognized practices those MOC credits, overall reducing that burden on clinicians to take on any additional activities. You can also reduce clinician burnout. This has been a huge problem in the industry in the past few years. How this does this, the PCMH model ensures that team members are operating at the highest level of their knowledge, skills, abilities, and license within their assigned roles. So what that means, physicians don't do what a nurse can do, and nurses don't do what a front desk staff can do, so on and so forth. It really helps to streamline processes and standardize procedures to keep that practice and staff really performing at the top of their ability and keep operations running smoothly. And along those same lines, a lot of providers like to use the NCQA PCMH recognition to actually perform a gap analysis and implement processes and procedures that improve care for patients and make your practice just run more efficiently. Another really important factoid to highlight, which I get a lot of questions on when I'm talking to practices upper management as well, is the ROI on PCMH. So practices that implement the PCMH model, they need to consider the business impact from investing in PCMH and effectively plan for how that implementation impacts them financially. So you have to ask yourself, what are the operational and financial considerations for becoming this PCMH recognized entity from the perspective of a primary care practice? So, costs of PCMH recognition could include things like new systems or structures or processes. It could be staff needed to support that transformation and deliver of that advanced primary care, or bringing someone in to help you. So to identify the potential business impact of PCMH, NCQA actually engaged Milliman. It's the world's largest kind of provider of actuarial services to answer this question. They actually modeled this impact and what it would have on revenue and costs at a hypothetical practice with 10 primary care clinicians and 20,000 unique commercial members. And they concluded that the revenue impact for that hypothetical practice was between 2% to 20% increase in revenue, again, dependent on the payment models. So in all payment models, revenue increases for a hypothetical practice and it outpaced the cost, resulting in a positive ROI. I think a lot of practices who are considering this aren't sure how to relay the value to upper management or are often tasked, with the burden to prove why this would benefit the practice and its patients. And even practices who are already recognized and you're now phasing into annual reporting, we're finding that, you all are responsible to defend your PCMH status to management, asking, why are we doing this? Is it even worth it? So we wanted to provide you with the tools to kind of elevate that conversation as a whole right off the bat. So now on to the actual recognition structure, just as a high-level overview of eligibility and the process. So I already mentioned we'd be focusing on NCQA PCMH recognition specifically, and that's because NCQA offers the most widely used PCMH recognition program for providers, and it's using standards that were actually redesigned in 2017. So again, this NCQA PCMH program is the most widely adopted PCMH evaluation program in the country. Now, I will say other accrediting bodies, for instance, Joint Commission or URAC, as well as a number of local, state, and national PCMH recognition programs exist. There are even some payer-specific PCMH programs I've seen and I've worked with. However, the NCQA program is the gold standard. It's what almost all EHR vendors recommend and work with, and truly is the industry standard for patient-centered medical home, which is why I said in the beginning, if you are participating in one of these local, state, or even a payer PCMH, this webinar, I can almost guarantee you, will still be helpful because so many of their requirements probably align with NCQA or were modeled off them. So the current program is that NCQA PCMH 2017. There used to be a 2014 and 2011 program. The 2014 program ended on October 1st of 2017. So this redesigned program, when we had first gone through and done this webinar a few years ago, was considered brand new and right out of the gate, and a lot of questions surrounding this. So I think most people are familiar with how this new program is working, but just kind of as a refresher here, this 2017 program focuses on ongoing sustained recognition status with annual reporting instead of that old 3-year recognition cycle. The 2017 program also reduced the total criteria from 167 to 100. And then there's this new core and elective approach, which allows practices kind of more flexibility to tailor the program to your patient population. So, I mean, in my opinion, the program is much more manageable now. They've reduced a lot of the paperwork and actually increased NCQA interaction while really focusing in on performance and quality improvement. So just a quick then and now, you know, you used to have to self-guide yourself through this recognition. You now actually have an NCQA rep who's assigned to your practice to help guide you and be a resource for you. You also used to submit your documents all at one time for transformation. Now you have gradual submissions and steady feedback using the QPAS system. Kind of on that same note, it used to be a pretty cumbersome, not very user-friendly survey tool. And again, now we have this QPAS system. It's much more intuitive and easier to use, very user-friendly. And then again, there used to be this 3-year recognition cycle where you had to basically retransform every 3 years. And there was 3 levels of PCMH, if you remember, kind of back in those days of level 1, level 2, and level 3. Now, you know, there's yearly reporting and it's just not as intense. And there's no more levels. We have gotten rid of those. It is now just you're recognized or not. So why they changed this, you know, practices kept asking for more interaction with NCQA. It was far too challenging for smaller practices. And there was a lot of emphasis on the process versus the actual performance of practices. And NCQA also thought, you know, practices should be demonstrating ongoing improvement, checking in every 3 years. You know, who knew if you were keeping those processes and procedures in place? So if you're asking yourself, you know, this all sounds great, but where do I even begin? The first place I would start is with eligibility. Clinicians who are eligible are those that hold a current unrestricted license as an MD, a DO, an advanced practice registered nurse, or a PA, a physician assistant. And only clinicians who can be selected by a patient as a personal clinician are eligible to be listed, in addition to the practice recognition on the NCQA's website. Now, an eligible practice would consist of 1 or more clinicians who practice together and provide primary patient care at a single geographic location. So what practicing together means in NCQA's eyes is that all the clinicians in a practice follow the same procedures and protocols, and they have access to, as appropriate, and share medical records for all patients treated at the practice site. These also need to be outpatient primary care practices, and a practice, again, in NCQA's eyes, is a clinician or clinicians practicing together at a single geographic location. So to be specific, this can include nurse-led practices in certain states. However, it does not include urgent care clinics or clinics only open on a seasonal basis. Now, it's important to note, I keep emphasizing this when I'm talking, recognition is achieved at the geographic site level, 1 recognition per address. And that sometimes gets lost in the mix when we're working with clients. It really depends on the actual physical location. And the MDs, DOs, PAs, and APRNs are listed on the application, since again, all eligible clinicians at the site must apply together. So the clinician should be listed at each site where they routinely see a panel of their patients, and non-primary care clinicians should not be included. So this means at least 75% of each clinician's patients should come there for first contact of care, if they select them as their PCP, and they are the ones providing that continuous care or comprehensive primary care services. Now, there is multi-site eligibility available, but you have to answer yes to all 3 of the following questions. You know, can your organization sign 1 PCMH program agreement to cover all the sites? Do all the practice sites applying for recognition share and use in the same way a practice management system, a registry, or an EHR to document patient care and for admin and billing? And do all the practice sites applying operate under at least some of the same policies and procedures? So we found if you can answer yes to all those, you are eligible for multi-site recognition, which means you can share credit across sites. So you would have 1 primary practice, you know, that submits all that evidence, and then it can be shared by the rest. There are some criteria that are marked as site-specific, but overall, this makes the process much easier for larger multi-site practices. So let's go ahead and dive into the scoring structure and look at the standards. Probably one of the most complicated kind of parts of this transformation is truly just understanding the scoring and the structure of this program. So I will kind of repeat the general concepts here a few times because I know it at least took me a few times even in person with these trainings to really get a grasp on it. So once you determine if you're eligible, the next step is really understanding how this works and what you have to do to meet these requirements. So today, the program's evolved to feature a set of 6 concepts. So these are the overarching themes of PCMH. So to earn recognition, your practice has to complete criteria in each concept area. Next is competencies. Competencies actually just categorize the criteria. They don't offer credit. It's just a way to think about or group the criteria in your head. I will just say that, they're not super relevant. It's almost just like buckets to put these topics in. Next is criteria. These are the specific activities in which a practice engages in to demonstrate that it meets recognition requirements. These are the individual tasks or things you do to make you a PCMH and actually transform your practice. These are the most important ones. And then within the criteria, there are components, which are the individual parts of the criteria where evidence is actually attached. So credit is assigned at the criteria level, and evidence to support that activity is attached to a component. Again, this took me a while to conceptualize and really get a grasp on how this works. It wasn't until I really dove into the standards and guidelines that I understood how this structure actually functions. So if you're confused, don't worry. I'll explain it again. You probably aren't alone, and we have examples. So the 6 concepts or overarching themes of PCMH, they're fairly straightforward. I selected this graphic with different shapes and sizes on purpose to show you which ones have the most amount of core criteria found in them. So you have team-based care and practice organization. This focuses on practice leadership, care team responsibilities, and really orientation of your patients to what a PCMH is. This is a smaller square, which means it has a lot less criteria that's required compared to the other standards. Next is knowing and managing your patients. This deals with data collection, think medication reconciliation, clinical decision support, as well as connection with community resources. This is one of the largest standards with the most core criteria required. Then we have patient-centered access and continuity. Again, this focuses on actually access to practice and clinical advice, care continuity, as well as patient empanelment. Care management and support, pretty self-explanatory, identifying patients for care management and looking at patient-centered care plan development. Care coordination and care transitions is just what it sounds like as well, management of lab and imaging results, tracking and managing patient referrals and care transitions. And then lastly is performance measurement and quality improvement. This is another big one. It focuses on truly collecting and analyzing performance data, setting goals, and actually improving practice performance. So you'll see for every criteria a breakdown like the one you're looking at on your screen. You have a concept which uses the 2-letter abbreviation when identifying it, such as TC for team-based care. Then the competency, which again is just that subgroup, it doesn't really matter. And then the actual criteria, which states the PCMH requirements, which is always shown as a 2-letter abbreviation, then a number, so TC01. And then you see you have evidence, and under the evidence, there are 2 components listed that you will have to attach evidence to get credit for that criteria. So it can sound confusing when you're trying to talk it out. I think this visual helps break it down and make it more meaningful to see how this structure works. So to receive recognition, practices have to complete all 40 core criteria and then earn 25 elective credits. So elective credits or criteria are a mix of 1 to 2 credits, and they have to cover 5 out of the 6 concepts. So each criterion in the standards is noted with an assigned value, and you can see the image on the right. It's actually showing how many credits are available under each concept and competency. So you have 40 core criteria, and then you have 60 elective available. where you only need to earn 25 credits. So here's another graphic to better understand how the elective scoring works, and also one that shows you the breakdown of core criteria within each standard. This will show you exactly why I made the blocks different sizes. On the previous slide, you can see KM and QI clearly have the most required core criteria compared to, TC or CM. Now, you may be wondering, okay, how do we meet this criteria, or how does NCQA know we met it? And that's where that evidence comes into play. So you have to submit evidence demonstrating performance against that criteria. You're encouraged to implement and document process-based evidence early in the process. So those need to be in place for at least 3 months, any type of documented process. And then any type of reported data should be no more than 12 months old. So really key guidelines here from NCQA when you're going through that transformation process. But think of an audit. You have to back up and prove you're doing something. This is the same idea. You need to prove you're actually meeting the criteria you selected by submitting evidence for that. And there are 2 types of evidence, either documented process or evidence of implementation. So documented processes are exactly what it sounds like, written statements describing your practices, policies, and procedures. Think protocols, practice guidelines, any type of agreements, some other documents describing, actual processes or forms. Could be referral forms, maybe checklists, some sort of flow sheet example as well would fall under that. And then we have evidence of implementation. This is a means of demonstrating systematic uptake and effective demonstration. Think of anything under the sun here, reports, materials like a brochure for your practice, screenshots, patient records, patient examples, your ECQM reports, survey data, etc. Even NextGen transfer credit, which we'll talk about as well. Really, evidence of implementation is the catch-all for anything that's not a documented process, I guess is the best way to put it. So you can submit this evidence either online through the NCQA PCMH portal, which is called QPass, or through what's called a virtual review, which is basically just like a Skype call with an NCQA evaluator. Now with QPass, you're uploading things like policies and procedures, like I said, practice pamphlets, or even a link to your website. These are things the evaluator can review on their own time. They shouldn't need too much of an explanation. This type of evidence can also be uploaded once and then linked to other criteria. So for example, if you have something on your website that actually meets 2 criteria, you would upload the link and then link it to both criteria. So you'd only upload things one time. It's extremely important to note that you should never upload anything with PHI on it. If you do decide you want to upload screenshots from your EHR to meet a criteria, you can. You just need to, insert a box over the PHI in Word and then take a new screenshot or save it as a PDF. However you want to kind of cover that PHI, you could upload it. That's really what the virtual reviews are there for. So that brings us, to our second type of evidence submission, which is newer and has received a ton of positive feedback, and that's the virtual review. A practice actually has 3 reviews, and during each of these calls, you're screen sharing with an NCQA evaluator, and you're on that call with them. So when you're in these calls, you don't have to hide any PHI. These calls aren't recorded, nothing like that. It's a secure environment. And this is why EHR demos to meet a certain criteria are encouraged to use during this process versus a screenshot and removing the PHI. You can also show reports at this time as well as patient examples. So this is new in the past 2 or 3 years, and it can be a bit intimidating for first-time practices. However, it really is to your benefit, to talk to that person and explain yourself and let them understand where you were coming from for certain evidence. But this is also where I get the most amount of questions. So I did cover virtual reviews in detail next with kind of best practices and tips and tricks from multiple NCQA evaluators that I've talked to. Now, if we really kind of put it all together, we have the concept, the competency, the criteria, and then the evidence required to support the criteria being met. And you'll see the 2 types listed. And then you have guidance from NCQA as well. And the guidance includes things like expectations, terminology used, aspects of the evaluation process, things like that. And it's extremely helpful. Never overlook the guidance. But that is it. That's, how you determine what's required of your practice to become a PCMH. It's the transformation to meet those requirements and providing that evidence to support your activities that will earn you that recognition. Now, the process behind the scenes, of not only the structure of it, but once you've met the core and elective criteria, kind of what's left to look at. So first off, starting from the beginning here, if we're taking out the core and elective criteria process, you want to determine if you're eligible. And then we recommend performing a gap analysis of your practice and identify, where you might need to transform things. You're looking for things like, does your practice have leadership in place? Do you have a certified EHR with pre-validated transfer credits? If you use NextGen, you do. Do you have a communications plan to engage patients, including a patient portal, as well as designated patient panels? Do you participate in any kind of value-based agreements, or do you report ECQMs to CMS? Things like that. You would then, kind of after taking stock, would enroll in NCQA QPAS system. Once you do this and you set this up by choosing your sites and adding clinicians, once you sign the agreement and pay the fee, that's when your 12-month transformation period officially begins. This is why I say you should really have reviewed the requirements and started making changes and getting things in place for at least the core criteria before officially starting in NCQA's eyes, because there is kind of a time limit on this. So again, you'll use QPAS to gather evidence, prepare the documentation, track your progress. And then once you're really enrolled and working within that, NCQA assigns you a representative, and they're your single point of contact to guide you through the process. So your rep should schedule a call with you to introduce themselves, discuss the process, develop a review schedule for your 3 check-ins over the course of your transformation. Really, your NCQA rep is your best friend. They are your lifeline and they are your best resource. They're not the ones conducting your virtual review. An NCQA evaluator will actually conduct your virtual review and determine if you meet criteria or not. Now, once you've completed your check-ins and you've earned your recognition, each year after, the practice actually checks back in with NCQA to show it's, ongoing with these activities and it's consistent. And this is what's called the annual reporting process. And it requires you to attest to certain policies and procedures and submit some data, much less than transformation. Now, the review process is, like I said, kind of that last and most critical step. And I mentioned there would be up to 3 check-ins during this review. So during these, you want to make sure you predetermine criteria to address. So focus on core and documented processes first, then identify criteria for 25 electives. Provide documents for offsite review. So again, any type of policies, procedures, website links, attestation, transfer credit, things like that. And then also provide evidence during these virtual reviews or check-ins. Make sure you are communicating with your evaluator. Like I said, I know it can be scary sometimes, but they should be your resource. You want feedback from them. Substitute evidence if something's not sufficient. It's a great experience to be on the line with someone and say, this doesn't meet it. Can you show me more? Showing them right away and getting that checked off. Demo your systems and provide reports. These virtual reviews give practices immediate and personalized feedback on what's going well or what needs to be improved upon. Like I said, a lot of times they seem intimidating. It's actually so much easier and better for you to develop a relationship and get that feedback and get a better idea of what that specific evaluator is looking for or needs to see. So as promised, what are some check-in tips and tricks coming right from either NCQ evaluators or PCMH CCEs as well? So first off, you need to know these are limited to 2 hours. That is it. Second, you need to know you have a maximum and minimum number of components you can have at each check-in. You will mark items in QPAS to go over in the virtual review prior to meeting, so you'll know exactly what you'll be presenting on to the evaluator. So my advice is to try and complete everything in 2 reviews, so you have an extra just in case you have any straggler criteria. Otherwise, you'd actually have to purchase a 4th. So due to the time and component restrictions, this is why we say upload all documented processes beforehand. Also, any transfer credit achieved by your EHR vendor, hint, hint, NextGen in this case, we would look at and actually does not count towards your total component. So that's a major plus. This means you can mark those as done and not include them in your total for those check-ins. Also, any shared credit, if you're using multi-site eligible credit, will be reviewed at one practice and then marked as met for all the rest. Again, with this first check-in, focus only on core criteria. You have to get these done, so make sure to run any reports you plan on showing before the call. You don't want to waste precious minutes watching your EHR load a long report. So any type of time-saving kind of mechanism you can do for these will be key. Other just general tips and tricks include have the right staff available. Have all the necessary people you need in the room. If you need a nurse, if you need your front office, your billing, IT, the worst is having something go down in the middle of it and you don't have anyone from IT and you're scrambling to try and get your screen sharing back up. Check your Skype setup and mic connection before the call. Have all your systems and reports ready and up 15 minutes prior to the check-in. Keep descriptions concise and to the point. You only have 2 hours. I'm a victim of this as well. I do this all the time, start rambling or really trying to explain something. Keep it short, let them ask you questions. You can revisit a criteria during the session if you have time. So you can always skip over it and go to the next if you feel like it's taking too much time. Again, these are all about preparation and organization to use your time wisely. So you can get a lot done in 2 hours if you're prepared. And then after the check-ins, the evaluator marks criteria is either met or not met. NCQA staff will review questions arising from the check-in. So after all 3 check-in, if you met all the core criteria and 25 electives credits, your results are forwarded to the review oversight committee. If the required criteria is not met in 3 virtual check-ins, you can purchase an additional check-in. And then same kind of along the same lines, if the survey process is not completed within 12 months, you can purchase additional time. But I'm going to go ahead and turn it over to Carly. Some of you probably are wondering, how the pandemic has affected PCMH recognition process. So she's going to go ahead and walk us through any changes that have been announced. So Carly, it is all yours.
All right, thanks, Lindsay. So NCQA has implemented some exceptions for the time frame between March 1st and September 30th of this year to help alleviate some burden on practices affected by COVID-19. So these exceptions are going to apply to all future surveys that include a look-back period between March and September. First, organizations do not need to credential practitioners who are not part of their practice and are providing care to members or patients as part of a federal, state, or local government emergency response team. Second, CMS allowed states to request an 1135 waiver that temporarily allows out-of-state practitioners to provide services if they're licensed in another state. When credentialing these practitioners in a state that receives a waiver, NCQA will actually waive the requirement that the organization verify the license to practice for that state. And lastly, NCQA understands that your normal operations have probably been disrupted by the pandemic, which could affect your ability to meet PCMH requirements. So NCQA will be flexible in their scoring during the March through September timeframe. However, you will need to provide documentation regarding the circumstances that interfered with meeting your requirements. And as a reminder, recognition practices can show evidence from any time in the past year. So if you prefer, you could demonstrate activities that were routinely performed either before or after that March through September timeframe. And it's recommended that if your organization has an upcoming survey or evaluation in 2020, you should contact your recognition account representative. And NCQA will be able to determine if you need any additional accommodations, such as a longer extension, and that's going to be on a case-by-case basis.
So we've taken you through a lot of the actual process of gaining recognition as far as uploading evidence to QPass or showing it in a virtual review. But we wanted to make this presentation really meaningful to help you understand what NCQA is really looking for to actually meet the criteria. So we went ahead and pulled 1 to 2 core criteria from each standard to briefly show you some examples of evidence. So first up is team-based care and practice organization. And the first criteria we'll discuss is TCO2, which wants you to define practice organizational structure and staff responsibilities to support key PCMH functions. So for this, you can provide an org chart and upload it to QPass. But lesson 1 with meeting criteria is you really need to read and reread the description and take it very literally. So this says structure and role or responsibility. So that means if you just uploaded an org chart that didn't list staff responsibilities under it, it would not meet the criteria. You need to meet both parts. So look at the example image on the top. This has both. You could submit an org chart that just has role and name that shows structure, and then submit a job description for each role on the org chart. If you already have those, and that's lesson number 2, evidence is flexible. So NCQA encourages practices to do what works best for them and to think outside of the box to meet criteria. There's no one size fits all when it comes to evidence, and that's not the point. It should really be unique to what fits your practice. Another standard under team-based care is TCO9, which states that you need to have a process for informing your patients, families, and caregivers about the role of the medical home and provide materials that contain that information. So this screenshot is from a pamphlet given to all patients in the practice that explains what a medical home provides. And you could also consider adding a similar section to your website and then use your website link as PCMH evidence to ensure patients with and without internet access can access this. Again, flexibility. And moving on to knowing and managing your patients, this section will really likely rely heavily on your EHR. So KMO3 asks you to conduct depression screenings using a standardized tool. And you can see we included screenshots of the PHQ2 and PHQ9. And also note that this example is filled out. So that's going to be a key for any screening tool that you show. It has to be actually completed. You can't just submit a blank template. Also, this may be a good one to show during a virtual review as a demo. And another good lesson is always pay attention to the components needed for each criteria. You may need a report and evidence of implementation or documented process, which means you need both to submit 2 things before this criteria can be marked as met. And you can always upload documented processes before, and then you can show the report or the screening tool during your actual virtual review. Now for KM09, this asks you to assess the diversity of your population. And again, this is a simple report. You could even make it in Excel using demographic data to show race, ethnicity, a vulnerable population, and language. So all of the required parts are going to be explained in the guidance of what exactly NCQA is looking for. And that's why I say don't skip over it. You'll most likely leave out a key piece of info that they want. So next section is patient-centered access and continuity. ACO1 is ensuring that your practice assesses the access needs and preferences of your patient population from collected data to determine if existing methods are sufficient. So if we look at the top screenshot, you can see survey result answers and then the pie charts that analyze the data. Now, what I want to point out here as a big lesson learned, especially with this standard, is that survey questions have to be actionable, meaning they can't just be yes or no questions. So, for example, instead of just saying, would it be beneficial to open another practice location to better serve you, which is just a simple yes or no question, you could add on to the end of that, if yes, please list your zip code so that you could actually make it actionable. Then for ACO5, that's asking you to document clinical advice and reconcile after-hours advice and care in patient records. So this is a great example of having to show two components, a documented process that states what the practice should be doing or what's the policy in place for this, and then you have the actual documentation in the medical record as an example of evidence of implementation. And next up is care management and support. So looking at CM05, does your practice provide a written care plan to your patients under care management? Again, don't overthink it. This could be a really good one to, again, just show during a review, so you can show that the care plan was reviewed and provided to your patient. In CM03, are you identifying your patients at high risk using a comprehensive risk stratification process? And this is a good example of another thing that you may come across, which is that some criteria are going to allow you to automatically meet other criteria. So for example, if you meet CM03, you'll actually get auto credit for CM01. And that's because CM03 is very similar to CM01, but it's just more sophisticated. So essentially it takes it to a whole new level by actually having a risk stratification process. Such as for this, you could use NextGen Analytics. Next, we have care coordination and care transitions. So for CC07, this considers available performance information on consultants and specialists. Again, two great examples here, one being an Excel spreadsheet that tracks a bunch of different things, and this can likely be used to meet multiple criteria, which is great and essentially killing two birds with one stone. And you could also go to Physician Compare and show data on the specialists your practice uses. Again, there's a lot of different ways to meet each criteria. Then CC01 is all about tracking, flagging, and notifying your patients of lab and imaging test results. So again, this is going to be likely dependent on your EHR, but you can upload the documented process to QPAS before your virtual review, and then show an EHR example on the virtual review, like the one from NextGen on here with the result in red. A lot of times these require both documented process and evidence of implementation, but you can see the level of detail on the documented process with the effective date and issue date as well. Remember, these processes really do need to be in place for at least 3 months to count. And if you are having trouble with documented processes that you don't have but need to create, there's a lot of online resources, and this is also something that a CCE could help you create as well. Okay, and finally on to our last category, which is performance management and quality improvement. So for QI01, you must monitor at least 5 clinical quality measures across 4 categories. The categories I mentioned will most likely be explained in the specific guidance for the measure, but if you're using NextGen HQM, this is an easy one. You'll pretty much have it met. And then we have QI15 and QI18, which are to report practice level or individual clinician performance results within the practice for measures reported by the practice, and also to report your clinical quality measures to Medicare or Medicaid. So again, use those HQM reports, for internally, maybe you have like a monthly clinician meeting where you're distributing their HQM reports and reviewing them. And then if you do use the HQM to submit to MIPS, you could just take a screenshot of your batch ID submission and that would count for that one. So again, meeting these criteria is not about reinventing the wheel. It's really just about making your practice more patient-centered. And if you're doing these things already, that's even more helpful. So we have some key takeaways and themes for meeting your criteria and gathering evidence that we've kind of picked up from both working with clients on transforming and sitting in on a lot of different NCQA trainings. First, evidence can be flexible. We saw this with a lot of different things that we just went over. A lot of criteria require a lot of different types of evidence. Again, documented process plus evidence of implementation, like a demo, is very common. Screening tools and templates must be completed. Criteria focuses on the entire patient population. So this is a newer one, but a lot of times really practices tend to collect data or focus on a subset of patients unintentionally. For example, with the team-based care measure where you're putting info on your medical home into a pamphlet, If you're only giving that pamphlet to new patients, then you're not focusing on your entire patient population. And then looking on the flip side of that, if you have criteria that includes the verbiage vulnerable population, you have to make sure you're actually focusing on a subset of your population. So whether it's Hispanic versus single moms versus homelessness versus veterans, those could all be examples, but the key that is that it has to be vulnerable. So comparing things like literacy rates in girls versus boys will not suffice. This sounds easy, but it is probably the most common thing to trip people up. Next, documented processes always need a date of implementation, and they must be in use for at least 3 months. And data used in your report should be no older than 12 months. Lastly, you want to make sure you have patient examples ready and know what patients were used in care management. Don't be surprised if your evaluator asks you to see multiple patients instead of just, 1 or 2 charts that you might have made perfect just for the review. Okay, so we'll quickly go over annual reporting. If you're already recognized as a PCMH, congratulations to you. So we are going to talk about annual reporting for 2021 since these requirements came out very recently. Annual reporting is used to sustain a practice's PCMH recognition. And to meet annual reporting requirements, you have to attest to some policies and procedures and submit evidence to NCQA. So as Lindsay mentioned earlier, PCMH was overhauled back in 2017, but NCQA did not want to leave those practices who became recognized using the 2014 standards at a major disadvantage by making them start transformation from scratch. So instead, if a PCMH practice is recognized using the 2014 Level 1 or Level 2 standards is approaching renewal, they'll be able to use a process called accelerated renewal. And then if they were a Level 3 2014, they'll actually be able to transition directly to annual reporting, just as a practice who met 2017 standards would. So after you're recognized, you have to complete annual reporting 30 days before your anniversary date, and your anniversary date is 1 year from your recognition date. During annual reporting, you'll be asked to attest that you are performing activities that make up NCQA PCMH requirements. You'll be asked to demonstrate that you're embracing measurement and quality improvement, and in some cases, this does mean submitting evidence via documentation or providing measurement data. We do want to note that your evidence for this can be provided at any point within the year, but it will only be reviewed after your reporting date has passed. So you can gradually upload this to QPass. And from what I've heard from clients, annual reporting requirements are flexible to meet your practice's needs, and you're probably performing most of the required tasks already. NCQA has stated that any new requirements are announced the July before the reporting year. This was September this year for obvious pandemic reasons, and the practice has to meet these new requirements by the next reporting date. And a quick note for any multi-site annual reporting. So all practices in a multi-site group are going to have the same annual reporting date, and that is going to be based on the date of your first recognized practice. So what does the 2021 annual reporting process entail? Basically, you'll submit the following into QPass, again, 30 days prior to your anniversary date. So it's going to be an annual questionnaire, basically saying you've maintained PCMH requirements, and then an evaluation where you're answering some questions, submitting some data, and uploading some evidence. Then NCQA will review your submission. And then finally, there's going to be a decision, which is going to be determined by the NCQA Review Oversight Committee to tell you if you have successfully maintained your PCMH recognition. Now, the following 2 slides are the 2021 annual reporting requirements and how they are aligned with PCMH criteria. NCQA does recommend that you download and review these requirements at least 6 months prior to your annual reporting date. And if your practice has maintained its patient-centered activities, it typically takes no more than 15 to 40 hours per year over several months to prepare for recognition. And then annual reporting should take a lot less time. Again, just the rest of those requirements. So real quick, what are the most common annual reporting pitfalls? So the main one is really overthinking. It's not that difficult, and really you should be able to complete your annual reporting requirements in a day or less. And then the second big one is missing your annual reporting date. You just have to remember it's 30 days before your expiration date or anniversary date. And I'll leave you with a very fun slide, which is audits. So there will be a random sample of practices submitting annual reporting requirements that are selected for an audit. The selected practice will be notified via email, and you will have to demonstrate some core PCMH criteria. Those are going to be conducted by an NCQA staff. It's going to be through virtual review, and the selection will occur after annual reporting is complete. All right, so I will go ahead and turn it back over to Lindsay to finish off real quick with how we can help you with PCMH.
Great, thank you, Carly. Now, I would say the important part, how we can help you besides just talking at you for an hour and probably overwhelming and confusing you guys. How we can make this transformation and annual reporting process easier on your practice. First and foremost, NCQA does offer pre-validation for EHR vendors. So what this is, they basically have pre-validated health IT solutions, saying that they have successfully demonstrated that their technology has functionality that supports or meets one or more of the criteria. So then practices can actually apply what are called transfer credits as evidence of implementation for applicable criteria. These are basically just gimme points. So you say you're using NextGen EHR and you get automatic credit for things. So NextGen Healthcare actually has pre-validation for the 2017 NCQA PCMH and PCSP programs. So NextGen Enterprise has received transfer credit approval for 31 NCQA criteria, including 15 out of the 40 required core criteria and 16 out of the 25 elective credits. And then on top of that, they receive practice support. This means that the solution demonstrates aligned functionality that significantly supports the practice using that product for 21 criteria. And even NextGen Office, they also have received transfer credit for 6 of the criteria and practice support credit for 16 criteria. Now, in order to claim those transfer credits, you will need to request a pre-validation letter, which you can do through the Success community by opening a case. You can see an example letter here, as well as kind of an example pre-validation overview that would be sent to you as well. Also on the Success community are things like the capabilities matrix. This provides a summary of the NextGen Enterprise transfer credits, practice support credits, and any available reports that are already available in the system. So this is extremely useful and will really help you plan out your virtual reviews. And then lastly, from NextGen, they do have a PCMH report solution. So any practices, looking into a comprehensive package of PCMH reports, they do have this available as well. You would be receiving the report solution and an accompanying reports guide and report specification document. All of the following reports listed here on the slide are available within the PCMH 2017 report solution. Clients can always reach out to their NextGen account manager to look into purchasing these if you are going through transformation and you're interested. This isn't required by any means. It just does allow you more transfer credit, as well as a kind of a click of a button to get the reports you needed. And last, but I hope not least, your very own PCMH certified content expert. That's at PCMH CCE. I have been certified by NCQA through on-site training and an exam to assist practices in anything NCQA PCMH. So what can we or I do? Honestly, whatever your practice needs. But basically, Carly and I work together to assist you in determining, are you prepared to enroll and begin transforming? If we're coming in after that fact, we would help determine your pace and establish a work plan. We would work with your practice to identify what evidence needs to be prepared in advance and help you kind of go through this virtual check-in process as well. And, work through any post check-in plans and any next steps for annual reporting as well. We're actually taking a practice through the complete transformation process right now and working very closely with NCQA. So if you are thinking about this recognition, feel free to reach out and definitely let us know. So as you can see, while this transformation, may seem overwhelming, you do have a wealth of resources and people willing to help and support your practice to make sure this is successful. As always, if you're uncertain where your practice stands, let iTentive help through a variety of ways. And if you're interested at all, or you want to learn more about us, please go to our website, sign up for informative webinars and blogs. We do have some assistance with PCMH transformation, as well as MIPS, MACRA, and our fixed price on-site consultations for clinical workflow, revenue cycle, and technology. But we have made it to questions. I'm going to leave Carly and I's contact information up on the screen. Feel free to shoot us an email if you do have any questions that come up after this. I know we're kind of short on time here, lots of information. So I will leave that up, but if we did have any questions come into the chat, I will turn it over to Chelsea to handle those.
Perfect. Thank you so much, Lindsay, and thank you, Carly, and thank you everybody again for joining us. I know that was a lot of information and your heads are probably spinning a bit, but don't worry, we will be sending out a link to the recordings and slides, so you can always watch it again or get the details that you might have missed there, as well as you see Lindsay's and Carly's information up on the screen. So we're just going to go through the questions in the order that we received them. We currently only have 2, so we're just going to go through those, but if we get more, then we will answer those as well. So first question. Hi, I just wanted to say thank you for this webinar. It's very helpful. Way to go, ladies. Our practice is transforming now, and we have an NCQA rep assigned to us. You mentioned something about an NCQA evaluator in the slides. Is that the same person? I thought our rep conducted our virtual check-ins.
I can grab that one, Chelsea. So this is most kind of frequently asked question as well. So your NCQA rep and your NCQA evaluator are different people. Your NCQA rep is kind of your lifeline to NCQA. They're your person that you want to ask all your questions to. They're assigned to you at the very beginning and take you all the way through the end, and are basically your resource for any questions or concerns you might have, and help you kind of through the process on the admin side with NCQA related kind of account things, anything like that. Your NCQA evaluator is actually a PCMH CCE, either that works for NCQA or has been contracted in. They will have no idea who you are. They'll never have met you before, but they actually are the ones to conduct your virtual check-ins. So they are different people. So don't want to get that confused. If you reach out to your NCQA rep, they can help you schedule your virtual review, but your NCQA evaluator is someone completely new that will actually conduct your virtual review.
Great, thank you, Lindsay. Next question. How long do we have to complete transformation? Carly, you want to take that one?
Sure. So you will have 12 months to complete transformation from the time that you submit your payment in QPass. So it's not the date of your enrollment, it's the date of your actual payment submission, and then it's a 12-month countdown from that day.
Yep, and I'll add, you can purchase additional time if you needed to. We don't recommend that. We always recommend planning to only do 2 virtual check-ins and using the third as kind of a just in case. Same kind of idea with the timeline. We recommend really planning for hopefully somewhere around 6 months and using the extra time if you absolutely needed to. So just to kind of keep that in mind.
Okay, great. Well, looks like that's all the questions we have, but if you think of any more, you can always reply back to the email that I'll be sending with the slides and recording. Otherwise, again, you see Lindsay's and Carly's information up on the screen. Basically, any way that you can get a hold of us, we're happy to help. That's why we're here, so don't hesitate to reach out to us. This is a lot, I know, so, if you think of the question after that, just let us know. And thank you everyone for joining us. Stay safe, stay healthy, and stay happy.
Great, thank you everyone.